So I'm a computer scientist here at Harvard, not at the medical school, at the main campus. So technically that makes me a scientist. But decades before, I wasn't a scientist, but I was very, very ill. And I began monitoring everything about my body at that time in a really crude way. And I learned that I was intolerant to gluten. And that was an amazing discovery. The clinician that was working with me had no idea, had never heard of the word, because you have to remember, this was before the web. And what was really interesting is after the blood test confirmed it and so forth, was living with the disease, which turned out to be really hard because at that time you couldn't buy gluten-free meals and nobody quite knew what it meant. Anyway, it changed my life, and the fog that I lived in and all the difficulties I had as a youngster have all gone a ways now. So I come to you with that background because my professional life is very much about privacy. And in some sense, the My Data Can project brings both of these together, especially relevant to this audience. So My Data Can is a system, a publicly available service that we're hosting at Harvard to help individuals take control of all their data. And so there's no fee for it, and it's publicly available. The idea is to give you both a sense of privacy and utility. I understand that PGP is under an open consent model, but because we're talking about the full breadth of data of your life, the idea that not everything you necessarily want to give to everyone in a total open way, and that therefore you should have some control to have both utility. Just to give you a sense of the kind of data that's out there, the following fields are just collected on the births in the United States, drawn automatically out of hospital information systems. Copies are sent on to government agencies, and sometimes the data is supplemented by the interview with the mother at the time of the birth. It includes lifestyle questions, educational background, and so forth. Most of you probably aren't even aware that that amount of data is collected. For every hospital visit or visit that you make to a physician, the following fields are not only collected, but many of them are sold, required by each state in the United States. Most of us who have a job who've never been deficient on any financial obligation to our children are in a database called the Directory of New Hires. This is some of the information that's on it and given out. Immunization registries are kept. And of course, many of us are aware of grocery data, loyalty cards. This is a depiction of a place where a typical but hypothetical patient named Alice, all the places that information about her medical record may go. The point of these slides is to tell you that the bulk of the data in the world about you that you produce isn't even under your control. And the question is, in my case, studying what was making me ill wasn't about minute studies, but it was also about other kinds of data that's beyond, certainly before genomic kinds of information. And the kind of data that gets collected about you, you are aware of the first person to whom you give it to. Maybe they have you sign a consent. You're unaware of the other people who may be getting the data, and some of those people may have an adverse effect on you. So the idea of My Data Can is very simple. We will help you get all the data under your control, telecommunications data, financial data, all the data for which you're producing in other repositories, and as well as health data, and it would be under your control to give out in parcels of cans, as we call it, to use that metaphor, so that you can have some control and some accountability about how the data is being used. And furthermore, by putting the data in these kinds of repositories, we can also give you an incredible experience to learn more about your life. Some of our colleagues have already shown some of the significant benefits when you work across data, across different silos. For example, combining location data and health data in order to predict disease. So the architecture of My Data Can is very simple. We have an apps API, and we have a database API. And the idea is that there are a lot of data holders for whom we really look like a free database service because they can push the person-specific data into My Data Can. And then at the same time, there are a lot of third parties who are interested in finding and developing good ways that you can use this cross multifaceted data in order to improve the quality of your life. And you can sign up and say a particular app can use certain data and so forth. So this is a depiction of those different APIs. One of the most significant things about my data can compared to sort of other kinds of personal data vaults is that at Harvard we doubly encrypt the data. That means that we don't have a program, nor are we capable of actually seeing any can that you mark private. And so this is the most secure, and so it's only that which you give permission to that people can see. So what are some of the kinds of benefits? This is an app that records everywhere my smartphone goes. And then I can look at that data, and I can learn things about my daily pattern. Two of us are trying to find out in a public place where we are. We can share that can, and we can then co-locate and narrow our search to where we are, and so forth. And that's only one data source. I use that particular data source because it's different than the one that you may normally think of. Some of our colleagues have taken GPS data and medical data and been able to show things like how by changing a recommendation to a prescription, they could give you a drug that was more amenable to the person's lifestyle and thereby increase drug efficiency and efficacy. So these are just some snapshots from the old version of my data can. It has, this is an app. This is modeled after the Indivo project. So it can look a lot like a health data, but health data isn't the only kind of thing we solve. We also have these sort of drop-down kinds of models where you can put a lot of notes. Because the truth was, it was only through the notes that I was able to understand my own situation. And it was only by looking at those kinds of notes. This is a documentation about a cat had been rescued. And this kind of documentation actually saved his life. So I just wanted to introduce you to my data can, welcome you all to participate. Thank you.
You have a question?
Very interesting. Two questions. One, when you say you have control over it, do you just have control over the aggregated mass? Because a lot of it is being pulled from other places, which I would assume you had no effect on afterwards, or no more than you had beforehand. And secondly, how much activity, how much effort is required? Is it more gathering, or are you, when I see all those notes there, that looked like a lot of effort to me. What is the possibility if you want to aggregate things but are less interested in actually putting a lot of energy into supplementing?
So the first question about control. So what do we mean by control? So PricewaterhouseCoopers said that the health data market, the secondary use of health data this year, is a $2 billion market. And that's data for which my data is a part of, but I have no control over. But on the other hand, we are allowed by law now to get a copy of all of our health data. And if I had that data under my control, the truth is my data is more valuable. The collection of the data is more valuable because, in fact, it could be augmented. I've given because of the brevity, the one example I gave was combining it with GPS data. All of a sudden made it a richer source of data. So our model is very simple. We can't stop the $2 billion market that's out there, and we don't intend to. But we can build a much more valuable data resource that's far more resourceful than the data out there. And we can also do things like provide infrastructure so that it may not be the case that I need to give my data all the time. I might be able to just run computations, for example, on public health and other kinds of uses of the data for which the data is not given out, but the calculation is done and the aggregate value is given out, thereby retaining even more value. So our model is basically one that says the control is that the data sharing is more transparent, that you have more valuable data, and that the data can come back and be directly useful to your life, which is something that isn't happening in the other cases. And that's independent of what's going on there, so we're not disrupting their flows. The other second question that you had, it had to do with effort. So for us, part of what our job is to make that as seamless as possible, to make your utility, to get the data in, to provide the right infrastructure that makes that data flow easily, and to provide the right kinds of interfaces that make it easy for you and apps to deliver back to you some insight into the data specific to you. So in the example that you saw, I showed that example with the cat because when I look at a lot of the PGP profiles that are online, there is a good group of them that are very much about sharing their life in a detailed way. And so if you look at the annotations that were provided there, we provide that kind of mechanism. But at the same time, you know, we still encourage the flows of the regular field structured data in a nice way of formalizing it and so forth. So you can get involved in it in the level that you want. And the level of effort, if we've done our job well, should be minimal.
Just very concretely, for example, to aggregate all your medical records, how much, what would you have to actually do to do that to a significant level?
Well, that's a great question. So, and so I now have to give a disclaimer. I'm on the Federal HIT Health Policy Committee, and so anything that I say is not the position of the Obama administration or of Congress or any other government agency, but my own. In fact, I'm supposed to say not even my own. But the answer is to how do we do that in a seamless way is to tap really good resources. So for example, there are collections of insurance claims data. And at the minimum, I should be able to have all of my claims data come in seamlessly. You should be able to authenticate yourself to My Data Can, and all of your claims data should just be there. Prescription data are already nationally collected. So I should be able to authenticate myself, and not just my current prescriptions, but any historical prescriptions that are stored there should be able to come and be populated immediately. Similarly with telephone records, text messages, ... And so to that extent, those kinds of pipelines are easier. Now, if the stimulus funding works, and these new electronic medical records work and people get on board, and in theory in 3 years, it should be more seamless to get it out of your physician. But we actually have a better way too in My Data Can. And one of the ways that we have is that we actually provide provider portals. We make it really easy to port data into My Data Can, but we also provide a good way for physicians, emergency rooms, and so forth to also get data out. So you can have a can called an emergency contact can. So it will tell allocations, allergies, medications, and who to contact in case of emergency. You can also have, well, lots of facilities. I can go on and on. I'm getting the look from a few of you that I should stop.
Real quick. I love the idea. The ethical model is very, very interesting. How many users do you have today, and when will My Data Can accept new users?
Okay, fair enough question. So we started 2 years ago with the idea and really working it through. And as you can imagine, to get it through a place like Harvard takes years. So we were really motivated to go online sooner because of the loss of Google Health. And so we really wanted to go online last fall. And what we were able to do is to start piloting and start setting up pilots of uses, and then we re-engineered it and re-architected in December of last year. And actually, version 2 has only gone live for the last month. One of the first places that we intend to open it up next month is to all of PGP participants. And then, in fact, we have 5 or 6 other sources that we intend to open it up. And then we have some pools that are just large. There are geographical areas in the United States where one hospital or provider organization accounts for a lot of people. And so we've also gone there. So we have a lot of parallel things. Some of my other colleagues, though, have been working very hard in the telecommunications space to make sure that the telecommunications data comes in, and their agenda and their timetable looks a bit differently. Everybody who gets there, no matter what your reason, whether you came through because of health data, whether you came in through telecommunications or shopping data, or what have you, all get access to all of the apps across those venues. So I didn't answer your question about when will the general public be able to get hold. We don't know the answer yet. We're trying to sort of kind of control it by these types of uses of data. We want everyone to have a great experience, and so this is one of our ways of doing that. But ideally, it's a function of months, not longer than that.
Thank you very much.